One, your live doctor.
And good afternoon. I almost said evening. It almost is. Shot. Dr. Deukmedjian, and we're getting ready to perform a Deuk laser disc repair. What is that? It's endoscopic spine surgery. Shot. AP. And to start all of our endoscopic spine surgeries, we start with a spinal needle or needle. And the needle gets us where we need to go. All right, so wow, I'm way over on your side. Shot. All right, back to a lateral. Looks good. Our patient has had a fusion before, just like the last one. And unfortunately, this patient was injured in a motor vehicle accident, I believe, or I think it was an MVA, right? Yes. Not a slip and fall shot. AP, quick. And as a result of that injury in the motor vehicle accident, now quick AP, this patient has a herniated disc in the neck. Shot. I think I was a little off to your side. It's amazing. Shot. Shot. All right, give me AP. Just a quick AP now. I don't want you setting up. All right, that's perfect. Now lateral. So the quick AP, just to make sure I'm in the middle, which I am. Shot. There we go. So you've just witnessed the hardest part of this surgery. I think the hardest part. I mean, there is one part that may be harder, and that is when I get back to where the herniation is, sometimes there's a tear in the posterior longitudinal ligament, and the herniation goes behind that. Then that's a little bit harder because you got to laser away the PLL fibers to release the herniation. Blood pressure is perfect. Everything's perfect. Okay, so what you're seeing, folks, is a state-of-the-art spine surgery that will replace artificial discs and fusion. And it's done here near Orlando, Florida on the Space Coast with my team and I at Deuk Spine Institute. It's the only place in the world you're going to find this surgery done. It is anterior transdiscal surgery. Let's have a numbing medicine. So while everyone else is still doing fusions and artificial discs, we've moved to the next phase of spine surgery, which is to repair the disc rather than remove it. And whether you're doing did he stop like platelets and whatever else he's on? Because
he's not on anything.
he's on something.
Maybe it's must be
Yeah, needle is here. I've injected 1 mil, huh? But you can tell that he's got like capillary bleeding, you know. He's got like that platelet, anti-platelet effect, whatever it is. It may not be a medication, but it's something like an herbal. But thank you. Because his blood pressure is perfect. It's not high, and yet just the little needle injection, we've lost a full milliliter of blood. The surgery you're watching, we're not going to do fusion. We're not going to put metal. We're not going to put a metal plate or screws. We're not even going to put an artificial disc. We're literally going to repair his herniated disc, and we're going to do it endoscopically. All right. So 2, 3, 4, 5, 6. Everyone agree we're at 5, 6. That is the disc we want to be at. We're going to do our discogram shot, which we just did. You can see there's a tear in the back of the 5-6 disc and the dye is leaking out. AP. We're done with our discogram. Now this discogram is not a evocative discogram. We're not evoking pain like when the patients are awake with the thoracic or lumbar. This is just a chromo discogram. Chromo means color. So beautiful. You can see the tear on both sides of the back of the disc, and we are in the perfect center of the disc. It doesn't get any better than that. So this is going well so far for our patient. I want to go back to a lateral view, and I want to take and there's a lot of pressure in the disc. All right, there's a reason there's pressure in the disc. Who knows? Good job, inflammation. Give her an A+ for today. Yes, inflammation in the disc, because inflammation is swelling, causes swelling, and swelling creates pressure inside tissues. So he has inflammation in his disc. I can already feel it. It's pushing. I hope it didn't push the guide wire out. Okay, good. But it was pushing the guide wire out a minute ago. So it stopped. There's still inflammation, of course. All right, we're going to make a little incision. It's actually 4 millimeter incision. I haven't even cut him yet. And there's still a little bit of bleeding. But we're doing a 4 millimeter incision. Okay, 4 millimeters is tiny. If you haven't ever seen 4 millimeters, it's about 1/4 of an inch. Okay, so it's otherwise known in medicine as a stab incision, but I don't like saying that because we're not stabbing the patient. Stab sounds so crude and unprofessional. Now, down the dilator, or down the guide wire, goes the dilator. And the dilator it does exactly that. It dilates. Dilate means to spread apart. So we're going to dilate the tissues gently as we make our way down to the spine. In the meantime, I've got to watch the guide wire to make sure it doesn't move. Isn't that crazy? And just like that, here we are at the spine with the tip of the dilator. Perfect. Are we pulsing?
Yes, sir.
All right, good. Yeah, reduce the radiation. I would bring the collimator together a little bit. You got way too much over exposure. That's better. All right, so now I'm at the front of the disc at C5-6, and we're going to pass through the annulus, and I do just a little twisting and pressure shot with my fingers. And once I get started, now I can actually take this guide wire out, because the guide wire has done its job and it's gotten me to the disc, and I don't want it to move forward and hurt anything like the spinal cord, which would be really bad form. The spinal cord, by the way, is just at the back of this disc. So now this patient is having a one disc repaired, the number 5-6. If I'm not mistaken, there are 2 discs that are injured, but he wanted to do just the one, I believe, first. And we always give our patients a choice to, we don't tell people what to do, we give them options. And we give them the pros and cons of each choice and let them make a decision. Okay? It's not my job to tell people what to do. It's my job to make the right diagnosis, to recommend treatment options and pros and cons, and explain the pros and cons and benefits of each treatment. It's the patient's job to decide what's best for them. Okay? That's always been my philosophy. If people want to know what would you do, Dr. Deukmedjian, knowing all you know, then I'll tell them. I'm happy to tell them. My opinion, what I would do. It's sometimes hard for doctors to put themselves in the patient's shoes, because we're not the ones taking the risk of getting fixed, you know? It's the patient. They got to take the risk. And we're somewhat protected as long as we don't do anything stupid that's deviation from the standard of care. So ultimately, the person that bears the risk of the surgery is the patient, and they need to be aware of what their options are. That's only fair. It's only fair. Shot? But a lot of doctors don't see it that way, and they're wrong. They're wrong not to see it that way. I have zero tolerance for their shenanigans. Shot. So, if you've been watching all of our surgeries today, we've done 2, and this is our 3rd. And the nice thing is the next 3, including this one, are going to be 1 levels. I like 1 levels. 1 level means we're just fixing 1 disc, and that means that it should be pretty quick. Okay? So if you've been watching so far, I have basically gotten into the disc through the front. We call this transdiscal because we're going through the disc. So this is what's really cool about the surgery. I actually dreamed of this surgery as a reality before I even knew it existed. What do I mean by that? Well, I'm one of those intellectual types that likes to think about what I do. And you're taught as a neurosurgery resident how to do an ACDF, anterior cervical discectomy and fusion. Okay, it's what everyone else does. There's 1 million done every year in the United States. And that's what I was taught to do, anterior cervical discectomy and fusion. With an ACDF, you're going to make an incision like this. It's a traverse incision from the midline or Adam's apple all the way to the side. You're going to open all this up, move everything over. You're going to create a lot of scar tissue and bleeding. You're going to do damage to everything in there. And it's impossible not to. So that's what I was really excited about learning to do. I was taught if someone has a herniated disc and they have symptoms of radiculopathy or myelopathy, you go in there and do this very invasive surgery, clean out the whole disc to get to the little piece in the back. And then you bring your microscope in. And using the microscope, you look way down there, and there's this little piece of herniation, smaller than a pea, and you pull it out, and you're done. And the whole beginning of the surgery, including taking the whole disc out, was for one purpose, to get to that little piece in the way back and take it out. So the Koreans, South Koreans, Dr. Sang-ho Lee, Dr. Gun Choi, they developed an endoscopic technique where you just left everything up here alone. You make a little cut, you go past the normal disc, you get to the back, in the back of the disc, and I'll show you that right here. Can you see here? Let's get some light here. Can you see this? Is that better?
Yeah, a lot better.
Fine. So here's the disc, all right? Here's the front. Here's the back. And in the back, there's a spinal cord and little nerves that come off like that, and they go down your arm. Everybody's herniation that needs to be fixed is always in the back of the disc. It's this little thing back here, okay? That little thing right there. So traditional ACDF, we have to take all of the disc out. All of this gets taken away with scrapers. I've done thousands of these. And then you've got just this little thing here, and you pull it out with a microscope and a grabber. Well, now you've got all this empty space between the bones. You've got to put a cage in there or an artificial disc and a metal plate. So I started thinking in my dreams, why can't we just somehow just leave all this alone and just get that little guy out? And then I found out the Koreans were doing it, and I went overseas and I learned from them. They probably don't even remember me, but I remember everything they showed me, and brought it back to the United States, and I started to develop my own technique that was better than theirs, and it still is better than theirs. So now there's only a few of us in the world that do endoscopic spine surgery, and literally cervical on the neck, there's probably 5 in the world that do endoscopic transdiscal surgery. So I'm the only one in the United States that does this, and I developed my own technique that's better than what's called discectomy. It's called the Deuk laser disc repair. And the reason it's better is because I actually can cure people's neck pain and headaches along with their arm symptoms. So the reason I can do that is because I go in and clean up the annular tear. All right, the pedals here. There's a little piece of disc material. We'll just wash it out. All right, we're at the back of the C5, C6 disc where the herniation is. I could see the herniation here. Can see the degenerated disc. The annular tear is this little white stuff. And we're just going to keep using our laser to zap away and debride the annular tear where the herniation came from. Okay, grabber. So by doing this, we're going to get rid of this patient's neck pain and headaches from this disc. Now, obviously, to get rid of 100% of someone's neck pain, you got to fix all the discs that are causing neck pain. And it turns out that in most people, it's more than one. It's two, sometimes even three. In this particular patient, I think there are two. But this patient wanted us to fix one at this time, and that's what I believe we're doing. So, again, this is the back of the disc, the herniation here. And the laser is doing its job of vaporizing this tissue that's causing all the pain. It's part of the herniation complex. What is the herniation complex? It really is three things: the annular tear, the interposed herniation, and the extruded herniation. The extruded herniation is the part of the nucleus pulposus that's behind the disc. It's only the nucleus pulposus that actually leaves the disc and goes into the foramen or epidural space. A lot of people don't realize that. It's not the annulus. The annulus doesn't go out of the disc. It's just a tear in the wall of the disc. So to get the herniation, you have to have the annular tear, yes, first and foremost, but then you have two parts of herniation. One that gets stuck in the annular tear and doesn't ever make it out, and then you get the part that actually makes it out and can actually push on the nerve or spinal cord. Okay? So what do we have to deal with? We have to deal with all three. To successfully treat a patient, you have to treat all three. And that's where other surgeons fall short, because they don't treat all three. They only treat the extruded disc material. They don't treat the interposed herniation, and they don't treat the annular tear. That's what separates the Deuk laser disc repair from all other spine surgeries that are done in the world, is we're the first to figure out that you had to treat all three. And as a matter of fact, we spend very little time on the actual herniation. And 95% of our time is on the annular tear. And that's why we're able to cure pain that other surgeons can't cure. All right. So this patient, other option would have been to do a fusion, ACDF, anterior cervical discectomy and fusion, or he could have also done an artificial disc. I'm sure there's somebody that would have put an artificial disc in him. Not me. I would, I could, I know how to do it, it's easy. But they don't work. They don't work well. And I don't believe in them. And they never will work well. They've reached their maximum potential. And their maximum potential has left much to be desired. From a patient standpoint, of course. All right, we have any questions from our audience?
Yes, we have a comment from YouTube. Will a vertebrae ever fuse on their own? And if they do, is it painful?
Yeah, great question. So somebody's saying, hey, Dr. Deuk, can two vertebrae ever fuse together on their own without surgery and without intervention? And if they do, is it painful? The answer is yes, they can, but it's extremely rare that it happens. And it only happens when the disc itself is completely destroyed through inflammation. Then the vertebrae can fuse, but you can't have a disc. Remember, for bones to fuse, for vertebrae to fuse, they have to be touching each other to allow the fusion. And if there's a disc still there, they won't be touching each other. So it's you got to get rid of the insulation between the bones, the disc, and then they will. It does not hurt to fuse. There is a condition called Ankylosing Spondylitis. Look it up, Ankylosing Spondylitis. It is a spondyloarthropathy, and it's basically where the joints fuse themselves, including the discs, and the fusion occurs around and through the disc. And it's a really weird disease. Like, people don't fully understand it. All we know is that your spine fuses itself. And now, that is a painful condition. I know the patients that have it are in pain. So if you don't have ankylosing spondylitis, I don't think that it hurts to autofuse, but it's also very rare. If you do have ankylosing spondylitis, then you will fuse and it will hurt. I don't know if that helps you, but. So Diego, why don't you show our audience, go ahead and run a video about how herniated discs cause neck pain. Herniated bulging discs cause neck pain.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain.
All right, so we just literally fished out a fragment of herniated disc at the back of the C5-6, and that's it right there. Now, a lot of people think a herniated disc is just like one piece, but it never is one piece. It's always multiple pieces. Sometimes you get lucky and you get a big one, but most of the time you're just going to get a bunch of small pieces like you're seeing right now. And I just got to break them up and bring them out. Rawhide.
Who was that singer? They get the song for the singer?
They made a movie about Aretha Franklin
Oh yeah, that movie looks really good.
and just released it in the theaters.
She is.
Of course, man.
I'm not. Except Depeche Mode has the.
Here's another fragment of herniation right there. But if you want to see one of Aretha Franklin's best performances on the silver screen, you got to go watch a movie called The Blues Brothers.
Oh, that movie is crazy.
One of the best.
That movie is insane.
And yeah, there's a live performance by her
That whole scene.
in that crazy old movie. It's a comedy, in case you didn't know. The Blues Brothers. You probably don't even have to pay for it nowadays. Just watch it on Netflix if they have it. But there's a scene in Blues Brothers in the diner where Aretha Franklin performs one of her songs, and it's amazing. She really does have an incredible voice. All right, we're bringing out multiple fragments. They're all small, but substantial. And it's just a matter of going in, getting them, and then, bringing them out. Why did I think about that? Because I thought of Rawhide. If you watch the movie, you'll know what I'm talking about. Huh? The scene where they sang Rawhide? Great scene. Great scene. It's one of the best movies ever made. And the chase scene is incredible, huh? The car chase scene. The whole movie is just perfect. Beautiful movie. It's the way movies were meant to be. They don't make movies like that anymore, unfortunately. Oh, great movie. So this is the back of the disc herniation. We've gotten out a lot of the pieces. This is all scar tissue from the injury. You're never going to get all the scar tissue out, so don't even bother trying. If you try to get it all out, you're just going to hurt the patient. But you can see where the herniation was. It was sitting right here, and there's some scar tissue still there. And my goal isn't to get rid of all the scar tissue. It's to make sure that A, we've unpinched the nerves, B, we've debrided the annular tear to get rid of the neck pain that's coming from this disc, and then obviously C, we don't want to cause any damage, any additional damage. Okay, that's not good to cause more damage. Ooh. So, you know, what's funny is when you look at the MRI, it doesn't look that bad. But when you get inside the disc, you see how much damage there really is. And why is the MRI not that bad? Anybody know? Well, the reason is because there's actually like a lot of scar tissue that's contracted, and it's sort of compressed the herniation into a smaller area, and it's under pressure, like when we put that needle in from all the swelling and inflammation. But you can't really appreciate it because look at all the fragments. This is not normal. Right, this happens with a severely injured disc. There's an old name for this. It's called internal disc disruption, and a lot of people don't understand what it means, but it means the inside of the disc is blown out. And how do you know about this? How do we know about internal disc disruption? We know about it from studying cadavers, dead people. You know, a long time ago, pathologists used to study the heck out of dead people. Like, we don't do that anymore because we think we know everything. But like really, really gritty, sweaty scientists, like the ones that wrote the books, the ones that we really should be paying attention to, they actually would like take patients in their community that were known to have back pain, right? Like, you know, old Mr. Jones, you know, he's had back pain for 20 years. And then when Mr. Jones died, they go down, the scientists would go down to the morgue, and they would like cut the body open, of course with permission, and then they would pull the discs apart and look at the discs, and they would cut them up and slice them and look at them under the microscope. And then they could see all the fractures inside the disc, and they said, wow, that's not normal. Like, a normal disc doesn't do that. It doesn't have that appearance of all these little bits and fragments. So the old pathologists figured out that people were actually, the people with back pain or neck pain, they actually had problems with their discs, and they called it internal disc disruption. Okay? And it's a term that is like an old ancient term that most people have no clue what it means. But it really means that the disc has been damaged pretty badly with some serious trauma, and that it's not seen well on the outside. Obviously, that's why it's called internal disc disruption, because it's internal. Can't see it on the outside. And so you may not see a big hernia and big bulging disc on the outside. You may just see what appears to be somewhat normal disc from the outside. But when you get inside, hey, that's when you see the real damage. It's like a bomb went off inside this disc. So this patient has a lot of the internal disc disruption with highly fragmented pieces of nuclear material that are just, that's what you've seen coming out. And this is a scarred area where
What levels is plaque? Do you know what level?
where the inflammation has been going on for a while. And we're fixing that.
What level he is. He's one level.
We're getting rid of the source of inflammation.
I think
What is the source?
that's one, but I don't.
It's the nuclear fragments, the pieces of herniation
You Google again?
that are interacting with the annulus fibrosis,
I mean, what's it called?
and actually
What does plaque have surgery?
causing inflammation,
The
because
answer
the
was there.
annulus fibrosis doesn't like the nucleus
Google
pulposus.
knows everything.
They're like mortal enemies. And the nucleus is located deep inside the annulus,
Oh, next.
to where it's
So plaque
protected,
is last.
where it's locked away, like a, you know, those
Shamoon was pulled in there twice. Not even
vampires, you know.
Shamoon's
I'm laughing because, you know, obviously I don't believe in vampires, but but in the movies, they always show the monster locked away in a cave, you know, and then somebody does something dumb and opens it, and then it escapes, and then it starts wreaking havoc. Well, that's what happens in a herniated disc. The annulus tears with trauma. That's same as opening the chasm or the cave and releasing the monster. And then the monster, of course, is the nucleus pulposus. And it comes out and just starts wreaking havoc on everything. People's lives, they get destroyed by this stuff. So what I'm doing is I'm getting rid of the vampire, and I'm allowing the cave to reseal itself.
Who's that?
All right, we're just about done, by the way. I hope you know that, right?
Shamoon's 3-4.
Like I need 2 more minutes and we're done. So we're going to wake this patient up soon. Our first patient already went home. Our second patient is about to go home if they haven't already left. And this patient will go home in an hour. This is outpatient surgery. Unlike fusions and artificial discs, most of the time, which are inpatient in the hospital, this is outpatient. There's no hospital stay. We don't even do the surgery at the hospital. It's done in our own surgery center. Very safe facility with the best staff, the best equipment, the best of everything. You okay? All right, 1 more minute and we'll be done. I'm just floating out the last of the herniated fragments. This is the annular tear, in case you were wondering. That white thing. That's the debridement I talk about all the time. We have to have some questions, no? It'd be a shame if we had no questions.
We have a question.
All right.
Yes. It's what is to be expected for the patient after surgery?
What? Let me grab that. Wait.
Sorry.
What is to be what?
What is to be expected for the patient after surgery? I assume it's for recovery.
Yeah, I expect this patient's neck pain to be gone. But they have another herniation, like I said. But so we'll get rid of probably 80% if I had to guess. And then this patient can go back to driving and potentially even working. They want it to work tomorrow. This is outpatient surgery that has a very quick recovery. Literally 1 day. You can go back to driving the next day. You could drive your car to work the next day. I expect any headaches they had from this disc to be gone. People with herniated disc get headaches in the back of their neck. And I expect their arm symptoms to be gone that are from this. So any pain, numbness, tingling, weakness, any of that stuff. So headaches, neck pain, arm symptoms.
We have another question from Facebook.
Mm-hmm.
If you treat C6-7, do you check the levels beside it to make sure they don't need any treatment?
No. Yeah, so the question is, if I treat a disc herniation, do I check the other levels beside it? So during surgery, no, I don't. We always go into surgery knowing exactly what we're going to do. We make those plans ahead of time. We don't change the plans in surgery. Surgery is not the time to be deciding what to do. The time to decide is before surgery. And that's why all the decision making is done with, in the controlled environment of clinic, where we see the patient, we do an exam, we review their films, and we of course decide what's best for them, for their treatment. Man, this guy's had a lot of damage, like I said. So we don't change the surgical plan during surgery. We do it all ahead of time. And I cannot see the other discs. I'm inside one disc and one disc only. So I have no ability to see what's going on in the other discs. And I don't do that. That would be dangerous and honestly pretty irresponsible. We're here to fix this disc and that's it. That would be like the police getting a call to an apartment complex because somebody on the first floor apartment is there's gunfire, gunshots, and then when they're done investigating that apartment, then they go check out everyone else's apartment. I mean, like, no, right? No, we don't want that. We don't need that. That's not the issue. So we're not looking for more things to fix. We're just here to fix what we know is the problem and leave it at that. I thought I'd be done in a minute, but, you know, unfortunately I ran into another vampire. And I just can't leave it here. But I think that should be it. All right, we're done. As I pull back, I'll of course see the shredded ends of the annulus. Again, this shows you just how bad the damage is from one injury, and you really look at the MRI, it doesn't look that bad, but the patient has horrible symptoms. And the sad thing is these people with this internal disc disruption, they live in pain because nobody takes them seriously. The doctors don't take them serious. They don't help them. And I already know why this patient's in pain. The problem is that we have to teach a million other doctors. And those doctors are stubborn, arrogant, and ignorant. And honestly, I just don't see it fixing itself. I'll be honest. So that's why we come here and try to teach people ourselves, because I can. All right, we're just putting some antiseptic in. Remember, watch the laser, don't let it break the fiber. And we're pretty much done. So I'm going to show you what we've done here on the outside and why this patient can go home just an hour after surgery, as long as our anesthesiologist does her job. All right, so move your hand, please. Here it is. You all see this tube? We did the whole surgery through this tube. You see the tube there? Yes, no, maybe so.
Yes, we do.
Good. All right, so I'm going to pull this tube out because we're done. And apply pressure for just a minute so it doesn't bleed. And then we're going to put a Band-Aid. We're going to wake this patient up, take the tube out, wake him up, and he's going to go home in about an hour. We've got another surgery, a single level lumbar, and then one more. So we got 2 single level lumbars. They should be pretty quick, I hope. What is the next one? What level?
Well, there's 1-3-4 and then the other one 4-5.
Oh, I love 3-4 and 4-5. You ready? So just hold it for a few minutes. 3-4 and 4-5, no problem. You know, at least it's not 5-1. That's the hard one. All right, if you have questions, please type them up. I'm heading over there. I'll answer them for you. And I'm going to go mark our next patient. Do our timeout. I'll call the EBL 0.
Deuk Laser Disc Repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours. 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself, whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
In 3, 2, 1. You are live, sir.
Oh, hi again, Dr. Deukmedjian, and thank you for joining us today. We just finished doing a cervical Deuk laser disc repair for a herniated disc at C5-6, and if you couldn't tell from the x-rays, you could go back and look in the beginning. This patient had a fusion done, not by me. It was done, I think, around 30 years ago. I'm not really sure the exact date, but if you look back at that x-ray, you could see on the side view that some of the bones were actually fused together. The number 6 and 7 were fused together. So he had had a cadaver bone put in there. Basically, the surgeon went in and cleaned out the disc with a scraper, like a little ice cream scoop scraper, and then packed in cadaver bone in there. And these two bones fused together. And he was doing fine until he got into a car accident. When you get into a car accident, a lot of times there's a whiplash type movement. And just think about that. If you're whipping forward, okay, then you're going to like rip the disc, like rip the annulus, rip the fibers in the back of the disc. And when you rip those fibers, and then with some like going back to work, lifting, carrying, playing sports, you're gonna put pressure on the disc, and that's gonna squeeze that jelly in the middle called the nucleus. It'll squeeze it right through that tear, and then you've got a herniation. So there's a lot of misunderstandings about spine problems, disc problems. We figured it out at Deuk Spine Institute, but the tear itself in the annulus is the first step in the herniation of the jelly. And once the jelly herniates out, it gets wedged in the tear, and that creates inflammation as the tear is trying to attack the jelly so the tear can heal. All right? It's the inflammation to get rid of the jelly by the tear to allow the tear to heal. That's where all the pain comes from, because the tear can't get rid of all the jelly. There's too much. But of course, the tear doesn't know that, doesn't have eyes. It just keeps attacking. And that attacking goes on and on for years in some people. So this patient had no problems, old fusion 30 years ago, doing great, got into a car wreck, whipped their neck, tore their C5, 6, and I think the C4-5 as well. And then jelly got pushed out, horrible pain, headaches, arm symptoms, and did not want another fusion. So found Deuk Spine Institute, recognized that we do things differently, and that we're able to fix those herniations without major surgery, without fusion, without artificial discs. So we just got done going in through the front, made a little hole here in the front of the neck, went in with a little, like a coffee straw, metal, not really a coffee straw, obviously, it's $500 coffee straw. Yeah, stuff's expensive. And use the laser and the scope to clean out all the herniated fragments and to debride the annular tear. And he's now out of surgery, and he's going to be recovering for the next 45 minutes. So here you can see the laser is zapping away, cleaning up the annular tear. There's some scar tissue. That was probably the video from the patient before, right? Because I don't think that was this guy.
Okay.
Yeah. So anyway, we're just showing you video from a different patient. But the idea is the laser goes in and zaps out the herniation. So let's take questions.
Okay, cool. So first question is, how far are you booked out?
How far am I booked out? I don't know. I really don't know. I don't keep the schedule. That's kept by my team, headed by Joe. And usually if somebody well, all right, I'll give you an idea. So I saw a gentleman yesterday in clinic who has a herniated disc at 045. And he's got left leg pain. It's shooting down his left leg. He's in agonizing pain. So he came in at the end of the clinic and he said, I want you to fix my disc with the laser. He came from St. Petersburg, Tampa, about 2.5 hours away. And I said, well, I'm going out of town next week. I won't be available next week. And he said, oh, I'm in so much pain. And I felt really bad for him. So I said, do you want to do it tomorrow, which is today? And he said, yes. So he's actually coming on and being done last today. He'll be our last surgery. He's a left side L4-5 for a herniated disc. And the reason we're doing him today, literally 24 hours later after he came in for the first time, was because he was in pain and he didn't want to be in pain anymore. And I felt badly for him. So we added him on, made our day a little bit longer. But at the same time, we're going to get him fixed today, and he's going to be really happy with his result. So the answer, I guess, is we could get anybody in. We could even do the same day if we had to. That's the nice thing of having your own surgery center, is you don't have to deal with hospital bureaucrats and nonsense and politics. We get to focus on patients and getting them better.
So, all right, and then this is a follow-up to the when you do surgery, do you fix multiple levels? But she says she asked that because she heard that people going in for one disc replacement and waking up and having 2 levels done.
So thank you for asking. I love questions because they give me insight into the way people think about things. And this person is saying, well, Dr. Deuk, I asked about whether you go in there and look around and fix other things, because I've heard about people who go in to have one disc fixed, just, you know, surgery on one disc, and they come out with 2 discs fixed. Okay. I've got to be careful how I answer that, but that should never happen, ever, ever happen. And I've been doing surgery for 26 years, and I have done thousands upon thousands upon thousands of discs. And not once have I ever had a patient that I've had to change what I'm doing during surgery. That's crazy. And I'll tell you why that happened. That happened because the surgeon did the wrong disc. And after he fixed the wrong disc, he looked at the x-ray and went, and then said, oh, we need to do another disc, the right disc. So that's why people don't broadcast surgery, because they fuck up all the time in surgery, and they don't want everyone to know about it. Why do we broadcast? Because I don't fuck up, okay? Sorry for the French, but the truth is the truth. And it makes me angry that people cover up their mistakes like that, because they lied to the patients, and patients deserve better than that. Patients trust their doctor. They trust you to do what's right. You know, if you screw up, then own up to it. Admit it. Tell the patient the truth. Of course, you're going to fry, but you deserve to fry if you're a spine surgeon screwing people up like that. That makes me angry. It makes me sick. Truly sick. So why did the patient wake up with 2 discs? Because the surgeon screwed up, did the wrong disc, and then decided to do the right one, because there was probably an oh shit moment in the operating room where the surgeon went, should I do another disc? And then, of course, they did. And that patient came out with extra surgery they probably didn't need. Okay? So that's what I believe happened. If I was a betting man, I would bet $1 million that that's what happened. All right? And why do I say that? Because spine surgery is one of those things where you're dealing with a bunch of different joints. It's really easy to go in to fix this one and accidentally do that one, because they're right next to each other and it's at the bottom of a deep hole. And to be honest with you, a lot of spine surgeons are just dumb, and they don't have the right equipment. They can't see things really well with the x-rays that they have, because they have the cheap garbage OEC GE x-ray machine that is a fuzzogram, and it's like, what disc is that? I can't really tell. Can you take another picture? Oh shit, I wish we didn't buy the $60,000 x-ray machine. I wish we bought the $180,000 Siemens, where I can actually see what I'm doing in the spine. So, you know, people don't like my answers sometimes, but they're the truth. And I'll bet you that surgeon screwed up and recognized their mistake at the end, and then decided to keep going and do another disc. So I'm sorry that you had to hear it that way. But believe it or not, it happens quite often, I'm sure.
That's it.
That's it. We got another surgery coming up. It's going to be another patient from out of state, Canada. He traveled down here to get the endoscopic Deuk laser disc repair. He has a herniated disc at L3-4, and it's in the foramen. And he's already had surgery in Canada, and the surgeon went in and basically did nothing. But of course, the surgeon would never tell you that. The surgeon said, I removed the herniation. But when you get the MRI after the surgery, it looks the same as before, except that the muscle is all damaged now because he went through the muscle and damaged it. So the surgeon went in, did a peek and shriek, we call it, and basically didn't do anything, billed the patient, got the money, and the patient has exactly the same symptoms that he had before surgery. So we're going to be dealing with that next. I'm sure we'll get that herniation out because my surgery is a lot better than what they do. And then our last case is the patient from St. Petersburg on the other coast, where he has a herniation at L4-5 on the left side and left leg pain. Okay, so we got 2 more coming. They're 1 levels each. They should be quick. And please bring more questions and popcorn.